CFHI, Child Family Health International, International Global Health Electives. These are designed for final year medical students. So depending on which education system you or your students are in, that could be fourth, sixth, or even eighth year students. I am Dr. Jessica Everett. I'm the Global Medical Director of CFHI. I am a family physician by training. I am a clinical professor at University of California, San Francisco. And my clinical work focuses on hospital medicine and palliative care. And my research focuses on the pedagogy of global health education, hence why we're here today. CFHI is a nonprofit organization that is bringing you this webinar. A little history about CFHI. It was founded by Dr. Evelyn Jones, who at the time was a medical student at Stanford University, and she wanted to do an international rotation, and she felt like the options available to her were not really aligned with her ethos. And she went abroad to shadow Dr. Edgar Rodas, who was a surgeon in rural Ecuador. And she realized that her frame of mind had been that she was going to help and to change the world. But in reality, she learned a lot more than she was able to give at that level of her career and training. Then she came back and she established CFHI to help other students and universities with global mobility under the auspices of a different lens. So the tagline that CFHI has, "Let the world change you," is an intentional play on words. We do believe that we can all change the world, but that there is a stepping stone process. And we're going to go into more depth about the nuances of that. CFHI has a global team in 10 countries. We have 25 plus programs that include electives, but also practicums for master's students, programs for residents, pre-medical, allied health, and other students. We have students who directly enroll in CFHI electives, and then we also have academic partnerships for health centers and universities to partner with CFHI to provide more options for their students. We have over 16,000 alumni and have been recognized through a variety of awards, both for our nonprofit transparency. We're in special consultative status of the United Nations. Our mission is three-part. So the electives and global health immersion programs, research into this area of work, as well as thought leadership and a commitment to help everyone who does global health electives and global health experiences improve their approach. So where are these electives? I'm so excited to introduce you to our teams and the opportunities. They are across the globe. CFHI focuses in low and middle income countries per World Bank definitions. You can see them there: Mexico, Ecuador, Bolivia, Argentina, Ghana, Uganda, South Africa, India, and the Philippines. And we're going to talk in more depth about each rotation and what the options are. I am honored to be here today. You are seeing me, but I am really just the spokesperson for a huge global team. These are some of our key leaders throughout the world. They hold the distinction of local coordinators, medical directors, country directors, and they are really the heart and soul of our programs. So I am speaking on behalf of many people from around the globe, and I am just one voice, but representing a huge team. So many of you may be familiar with global health as a discipline. It was defined in the Lancet in 2009. And when you look at the formal definition, it is defined as a field of study, research, and practice that places a priority of achieving equity and health for all people. It involves multiple disciplines, is both the health sciences and beyond the health sciences, and synthesizes population-based prevention, which is a synonym for public health, and individual level clinical care, which is a synonym for medical care or treatments that you may be used to. Really tries to promote interdisciplinary collaboration and emphasizing transnational health issues and determinants. You can see here that this definition does not have any geocentricity to it, meaning it is not just about what is happening in Uganda or India or Kentucky or Canada. Global health happens anywhere where there are health disparities. The United States is one of the leading countries with health disparities, despite huge health expenditures. So global health can be seen as a way of committing to, practicing, and understanding how we achieve health equity in a way that goes beyond just the myopic clinical lens that many of us have. There's various frameworks for this. I like this one, which is out of Canada and kind of helps position global health trainee. They use the word expert, but anyone who is pursuing expertise or insight into global health within a framework of the different roles that we play. And these actually map to ACGME competencies, so that we have to develop ourselves as communicators, as collaborators, as managers, as health advocates, as scholars, as professionals. And we do so through a variety of different means. So you see there formal curriculum, problem-based learning, e-learning, mentorship and apprenticeship models, practice and practical applied learning, including service learning, and like global health electives would be, as well as formative and transformative evaluation and self-reflection. Importantly, in global health, these competencies and the way we develop ourselves is housed within the values and principles that are foundational to health equity and global health. This includes social justice, solidarity, reciprocity, responsiveness and accountability, respect, honesty and openness, humility, and sustainability. Today, we're going to talk about how we actually bring those concepts to life. It's very easy to rattle off a list of values and principles, but what does that actually look like when you are vetting electives or considering going abroad as a final year med student, as a resident, or if you're a faculty member and administrator, considering how to organize and expand global offerings. So I want to focus a little bit about how international global health electives are different than domestic electives. And I think this is key because oftentimes I find that we have this concept that we're going to pick ourselves up from our usual rotations and we're going to put ourselves down into another place, and our role and how we're being and the context is going to be similar. We're going to be in a similar capacity. And the reality is, when students are international, trainees are international, or even professionals are international, there is a very different environment that we are entering, and our roles should not mirror what we're used to doing at home. And there's a variety of reasons we're going to talk about. Those reasons, to simplify, kind of fall into there's history, there's complexity, and there's a long arc of impact. So let's talk about how the history, complexity, and that arc inform global health electives and how we approach these. So let's look at history. So I shared with you that definition from the Lancet that was published in 2009. That definition actually was conceptualized at a meeting of the Consortium of Universities for Global Health in 2008. There was an alternative definition put forth that was proposed by an East African colleague. And he said that global health is, quote, a concept fabricated by developed countries to explain what is regular practice in developing nations. Reflect on that definition for a moment. A concept fabricated by developed countries to explain what is regular practice in developing nations. This definition is important for multiple reasons. Number one, it did not make the Lancet, and it is not something you're going to see in a lot of papers published about global health. Yet, it's a really important perspective and data point. Two, I think that word fabricated is a very strong and important word for us to consider what that means and where the spirit of this definition is coming from. So the history of even how global health is defined has not been balanced. In addition, there is a much longer history of experimentation and taking advantage of populations who are less powerful and less privileged. This is an example of Anarcha. John Marion Sims is considered the father of modern day gynecology. But what many people don't know is that he and his colleagues conducted over 30 unnecessary surgeries on this woman, Anarcha, who was a slave. So modern day medicine in many ways is based on practices that were actually taking advantage of marginalized and disempowered people. And that continues to happen in global health. Achebe says, until the lions have their own historians, the history of the hunt will always glorify the hunter. So I know when we're thinking about doing global health electives, we are not thinking about being hunters or being predators, but in reality, there's often ways that we take on colonial, racist, and other legacies in a way that is not constructive, that is not educationally optimal, that is not ethical. And so being aware of this history and more modern day constructs and criticisms of global health is really important. This is a recent commentary led by Hussein, who said, the field of global health continues to uphold colonialist structures. History demonstrates that acts of colonialism inevitably lead to negative health outcomes. Global health partnerships are also often ingrained in colonialism and may be counterproductive. So this is not just a historic dynamic, this is a modern day dynamic. And I want to bring this dynamic to life in how this can happen during global health experiences, rotations, and electives. This is a quote pulled from a medical school's magazine where they are celebrating these two students. I will read the quote. Dan and Christopher spent much of the summer caring for people in remote villages of Tanzania, where medical professionals seldom are seen. With little supervision from physicians, they traveled village to village, caring for patients suffering from malaria, HIV, chronic pain, and other illnesses. Just being thrust into a situation like that made all the classes we took the first year very real. You learn quickly that way because you don't have a choice. So knowing what you know, either being third, fourth year, fifth, sixth year medical students, faculty, or administrators, what are some problems that you see with this description of what Dan and Christopher did in Tanzania? I'm not sure if you can comment in the chat function, but if you can, put your thoughts on some problems you see here. If you can't chat with me, put some questions or thoughts you have in the question and answer chat box about what Dan and Christopher did. So reflect on this, and we're going to talk more about how this is problematic. Juan raised his hand. Let's see, Juan, if I can unmute you and go back here. Okay, Juan, I unmuted you. Can you speak?
Can you hear me?
Yeah, I can.
I was trying to type something, but it seems like the chat is disabled. I'm not
Perfect,
sure if
thank
that's the
you.
same for everyone. Yeah.
What are your thoughts on this?
I just think that like the message came the wrong way when they were trying to do good. I just feel like trying to help people without the appropriate supervision is probably not the best thing that you can do.
Thank you for that, Juan. And Kimberly, I see you have a comment. I'm going to unmute you as well. Kimberly, what are your thoughts?
Just noting the lack of supervision. So was that the best care for the patients? Like if we can imagine medical students here not being supervised, how would people respond to that? And then I also was just curious where it said medical professionals seldom are seen, and I just wondered if they recognized who the healers were in all of the places that they went to, because they might look different than what they're used to.
Thank you, Kimberly, for those comments. Yeah, and I couldn't agree more with both of you. I think when we kind of tried to map to these values and principles and what Dan and Christopher were doing and what their school actually celebrated them for after they got back, I think there's real questions about responsiveness and accountability, like you said, honesty and openness, humility, sustainability, respect. health equity. So as you can see with this example, it's very easy for global health electives and experiences to go off the rails and to really be misinformed and even problematic. One of the areas of research that I collaborate with a variety of institutions on is looking at these dynamics. And this is actually a study of licensed professionals. And it looked at the extent to which they are performing outside their scope of training and during global health activities and experiences. And what the data really showed was that even at professional levels where we're already licensed, we lack the expertise we'd like to have. And that lack of expertise falls into multiple domains: understanding the health system, understanding formularies, understanding burden of disease, cultural and socioeconomic considerations, and at times just completely ignoring existing health systems, which Kimberly, you highlighted really well. And that really gets us to some of those concepts around complexity and the arc of impact. So when we look at complexity, like Kimberly said, oftentimes we land somewhere that looks very different than what we're used to seeing. And so if you're coming from a high-income country, the United States, Canada, UK, Australia, other places, health systems may look like those buildings on the right where there's glass and there's signage and there's a clock tower. And that is the infrastructure that you're used to seeing. And that's the infrastructure that signifies to your brain that healthcare is happening. However, when you land in a place that looks very different, the health system may look very different. So the buildings on the left, even the individuals on the bottom left who don't have a building, but those are actually community health workers, which is an evidence-based primary healthcare system. So if you aren't cued in to that system existing and you're used to seeing those other images, then what your brain will do is it will actually ignore those systems and it will ignore what's going on and it will not know. And if you're on top of that told a narrative that there's nothing happening and you need to go across the world to help people, then you're even more cued into the fact that you think there's nothing happening, right? And so we so easily ignore functioning, robust, amazing, cost-effective, resourceful, ingenuous health systems that look very different than we're used to. And so then we come to conclusions like this, which is that we need to pack duffel bags of medicine, that we need to build makeshift pharmacies, that we need to have students handing out medications that they're not licensed to hand out. So that ignorance and that lens that's ill-informed leads to very misguided global health electives, internships, and experiences at all levels of medical education and professional practice. And in reality, there is a drug supply chain, there is a healthcare system in all ends of the earth, even those that are experiencing war. So these are examples of existing pharmacy supply chains and workforce who are, when you're doing this, the opportunity cost is you're not meeting these folks. You're not seeing what these folks are doing. You're not actually getting a version of reality that's aligned with reality. So when we go back to that definition that global health is a fabrication, this is how we fabricate. And it's a very tangible, and if you step back and look at how this happens, you can see it happening when you are even looking at global health elective options. And I'm happy to give you advice on what red flags to look at. But like Kimberly said, and is that Dan and Christopher did not even realize that there was a health system happening. And this is an example of a structure of a pluripotent health system where you have formal and informal structures, you have multi-tiered health systems, you have profit, for-profit, nonprofit, governmental health systems, all often acting in a certain geography. And so if you're told nothing's happening, or if that's your assumption based on what you see looks very different than what you know, if your school is celebrating that colonial superiority complex, then we've got some real problems for the type of global health electives that students may go on. Dan and Christopher also were not looking at a long arc of impact, right? So what does that mean? And why is a long arc of impact important? Peter Singer once said, more often there's a compromise between expediency and ethics. And we often don't look at the timeframes we have to engage as being crucial to the ethics or ethos of what we're doing. But in reality, that's what happens. There's much research and anecdotal evidence for what will move the burden of disease globally. This is an example of approaches that, if undertaken, would impact the burden of disease by 2040. You can see that these fall into different domains: prevention, health promotion, therapeutic, environmental, social, and behavioral. And they've kind of broken it down in a way to of what percentage, if we were able to get to a more ideal state, would impact the global burden of disease. So these are the evidence-based interventions that we want students to be cued into, that we want you to learn. These are what you want to learn about. Like, you don't want to learn about a fabrication. That doesn't help you as a physician. That doesn't help you as a partner, colleague, or a global citizen. In addition, when we look at this long arc of impact, we can look at initiatives such as the Sustainable Development Goals in terms of how countries and multinational efforts are tracking, investing in, and holding accountable progress in terms of human thriving and economic development growth, while also protecting the environment and creating partnerships and valuing the differences that we have based on geography, culture, practices. Development no longer is this uniform idea of everyone getting to the same goal in the same way. So back to Dan and Christopher, when they were thinking about their arc of impact, you can see that they were thinking that they need to go village to village unsupervised. Also, you all know, if you are far enough along in your medical training, you know that treating things like malaria, HIV, chronic pain are not things that you do walking village to village and handing out whatever they were handing out. So the solution is not fit for the opportunity here. And so the goal of global health electives that are well designed is that you are actually showcasing solutions that are optimally fit and that are the best standard of care that there can be in very challenging environments. So the question arises then, these are the problems, this is the pitfalls we can fall into. How do we intentionally counteract our bias in these fabrications? How do we recognize history? How do we recognize complexity? How do we recognize the long arc of impact? And I propose that there's some shifts that need to be made, and these shifts are made when we engage in electives that are designed in a thoughtful, contemporary way. So what are some of the shifts that we have to make? Well, we have to shift from certainty to curiosity. We have to shift from agent, from trying to be that change in the immediate sense in 4 weeks, to being a learner, to being a sponge. We have to shift from exceptionalism, thinking we know, or the places we come from have the knowledge, to humility, realizing that our knowledge, our insight, our understanding is extremely limited. And if anything, we have to unlearn before we can even learn. We have to shift from superiority to inferiority, realizing that many places that we're coming from to go to low and middle income countries are not exactly exemplary in the way that we are providing health equity and the way we're utilizing resources towards impacting our own community and populations. We have to shift from rushed to unhurried. When you look at dominance, superiority, and inferiority, you will see that one of the traits of dominance is often a sense of urgency that can sometimes be an artificial sense of urgency. And so while in many of our cultural contexts and our home environments, urgency, being fast, getting things done, action orientation, task orientation is valued and is celebrated, that is actually the opposite of what we need to do when we are trying to learn about global health and going into different environments and trying to be culturally fluent. We have to shift from accomplishment orientation to sustainability orientation. So it's not about what you can get done in 4 weeks. It's about what is getting done over decades. It's not, and you have to shift from simplification to complexity. So there is this psychological concept called the oversimplification cause fallacy. And it's a tendency of our brains to take very complex situations, and in trying to understand them, we will boil them down to a very simplistic cause and effect. And that doesn't serve us in global health or health equity, wherever that is happening. And so we have to shift from really understanding complexity. We have to shift from a deficit orientation, looking at what's going wrong, to an asset orientation, and I'll talk more about that. We have to shift from critic to admirer. And Stephanie pointed out, which I want to emphasize, that when we shift from agent to learner, when we shift from certainty to curiosity, when we shift from exceptionalism to humility, what we're really doing is we're making a shift towards an anthropological mindset, where we are really utilizing concepts such as participant observation, where we are trying to understand reality without disrupting it, which is very difficult when you're coming from a different culture, with often a different skin color, with a different language, with a different power and privilege balance. It's very challenging. But when you look at how anthropologists have done this, they've really tried to learn about with reality without interrupting it, disrupting it, or changing it. And so while that's counterintuitive, when we think about health equity, that's the foundation of actually impacting our world and our patients and our loved ones over our entire careers and lives. So how do we do this? So there are structural ways. This doesn't just happen because I say this is the way to do it, or this is like a good idea. You have to actually structurally build this in. And this is where CFHI electives have these intentional shifts that are built into the frameworks and the fabric of how the electives are run and structured, and who has voice and who has space and who are the experts. So some of the ways in which we do that is that we emphasize local existing health systems, and we embed students into these longitudinal systems. We are not setting up artificial activities that are not happening on a continuous basis. We recognize local practitioners' expertise and the ownership of knowledge by local community members, patients, healthcare workers, public health workers, and others. So knowledge and power are shifted to those that are local, not to the visitor or to the student who's doing their elective. We utilize asset-based community development and engagement frameworks, which is a formal framework that was kind of defined and built out in the 1990s at Northwestern University, but has been adopted around the world. And there's a very intentional process that you undertake. CFHI has undertaken this in the communities we work in, because this takes a very long time to understand assets, to map them, to really present a narrative and a story that's authentic and that's looking at strengths, and to connect you as students and faculty with those strengths. So students are inserted into relationships that have happened over decades and have been based on an asset-based framework from their inception. We adhere to fair trade learning, which is a standard of practice and a rubric and a community of practice that stems from the collaborative, the Community-Based Global Learning Collaborative, which was formerly called Global Service Learning. You can learn more by Googling the collaborative or going to CFHI's website under resources. We partner with the collaborative. We have actually helped inform the Fair Trade Learning rubric, and we are in a multi-year process to either further refining it for the CFHI global team. We also have robust pre-departure training, not only in key foundations of global health called the pillars of global health, but also in cross-cultural fluency, humility, health, safety, and wellness. I think increasingly there's a recognition that our own personal wellness and our state of mind very much informs how we are interacting with the world. And so ensuring that we are in our best selves and mind space and heart space, and that we have the tools for when we get stressed, anxious, agitated, annoyed, frustrated in a different cultural resource environment, are really key to us engaging in this way. So what are some of the learning objectives, both personal and professional, that you will gain from CFHI Global Health Electives? We draw on a variety of different sources for these competencies. This is a study that came out of USAID, and it looked at, USAID is kind of the bidirectional aid organization for the US government. They contract to do their work with a variety of contractors. And this is a study of those contractors. And it basically asks them, when you're hiring health professionals, doctors, and other health practitioners for international roles, but they've only had domestic experience, what are some of their weaknesses? Why don't you hire them? What are they lacking? And so the respondents to the survey, the employers who would be hiring you someday if you want to have a global health career, the number one weakness they cited was understanding the context and realities of global health. And so again, we go back to that anthropological framework where we want you to be a fly on the wall in some ways, to really deeply understand these realities and to unpack them for yourself and to confront your own misconceptions and unlearn the things that you've learned that are not accurate. So rather than oversimplifying and trying to tell you that you're going to go abroad in 4 weeks and save a village, I'm not going to do that. I'm going to tell you you're going to go abroad and you're going to understand the context and realities of global health. And that's exactly what future employers want you to learn. That's exactly what our global team and those that are hosting you want you to learn. The second weakness was flexibility, adaptability, and creativity. This is where we start to get into some of our intrapersonal and interpersonal tendencies and responses to stressors and situations. And so from pre-departure training to orientation, both we do an orientation virtually before you go abroad, and then you have an orientation in country, and then you have a team and collaborators that you're working with throughout your elective, and then post-experience debriefing. You will have many opportunities to demonstrate flexibility, adaptability, and creativity. And we use critical reflection as a way to also capture some of this development so that you can articulate it for future jobs, for residencies, for fellowships, for leadership positions going forward. The next mentioned weaknesses were cultural sensitivity and cross-cultural communication. I will speak to some of the curricular elements that we have to work on those competencies. And then the last weakness was knowledge of key player systems and processes, which again gets to some of these foundations of global health, both understanding who are the multinational players, who are the national players, the regional players, the local players, who are the systems that are in place, what are the processes that they adhere to, both those that help things in terms of health outcomes and those that can make things more complicated or challenging. Another source for the competencies that you will develop during a CFHI Global Health elective is the CUGH Global Health competencies. And these were defined, and there's now a whole toolkit behind these, but they fall into different domains, including the global burden of disease, globalization of health and healthcare, social environmental determinants of health, capacity strengthening, which is a term for training within health systems, collaboration, partnering, and communication, professional practice, health equity and social justice, program management, sociocultural political awareness, strategic analysis, and ethics. In terms of cross-cultural effectiveness, humility, and fluency, there's a variety of different approaches. These are 2 tools that are used pre-departure that both are validated self-assessment instruments. We partner with the COSI group to provide you the intercultural effectiveness survey and score, and we partner with Aparian Global to provide you a GlobeSmart profile. The GlobeSmart profile looks at 5 kind of cultural spectrums in terms of independent versus interdependent, egalitarian versus status orientation, risk versus certainty orientation, direct versus indirect, task versus relationship orientation. And the IES is really more about where we're at in our personal journey and what our makeup is in terms of those things that predispose us to be more likely to be interculturally effective in those areas of opportunity. These include continuous learning, interpersonal engagement, and hardiness. And the IES provides you with an exhaustive kind of report. and you have the opportunity to develop a personal development plan so you can lay out goals that you have for yourself in terms of where you can improve in these domains to make you more likely to be interculturally effective. So what are some of the options with CFHI to do electives? I know this is probably what you all were hoping to hear about, but I really feel like it's important to frame why electives are something to take seriously and why you need to vet the opportunities. I would love for you to partner with CFHI to go on an elective, but I also would be happy for you to choose an elective anywhere else that is adhering to the ethics, ethos, and understanding that I've kind of laid out. There's a website that CFHI developed in collaboration with MedSyn, which is a British global health medical student association, and it's www.choosinganelective.org. So www.choosinganelective.org. And it has some of the principles and concepts that I mentioned here to help students who are considering any elective option. So CFHI has electives around the world. I mentioned some of the countries. I want to go into a few of the specifics. In India, there's elective options in the capital city, which is Delhi, which India is the most populated country in the world. It surpassed China last year with almost 3 billion people. India has had huge gains in improving global burden of disease. Their gains in child mortality, under 5 mortality, actually account for over 25% of the reduction worldwide. So India has had amazing build out of their public health systems and their clinical care systems, health insurance schemes, and other advances. This elective, you can focus on public health, which is kind of, I think, the strongest focus of this elective. So if you're interested in augmenting your clinical exposure with public health exposure, this provides an amazing survey of public health foundations, including WASH, water and sanitation, women's rights and employment, delaying child marriage and structures to do that, prevention of infectious diseases, care for elderly populations, houselessness and marginalized youth, drug use and substance abuse, harm reduction. We partner with one of the largest harm reduction organizations in Delhi that provides HIV treatment, needle exchange, peer counseling, and empowerment. So there are also other tracks in Delhi. So if you're interested in public health, I would say this is one of the strongest sites. This, and I would say Kabbalah, Uganda, which I'll talk about in a bit. But also there's a palliative care track if you're interested in focusing on palliative care. There's also an ophthalmology track. So if you're interested in specialty rotations in ophthalmology or palliative care, this would be a great program. If you're interested in a broad-based public health exposure and building relationships in public health globally, this would be a great option for you. In Darjeeling, which is in the northern part, the foothills of the Himalaya, the rotation focuses on rural health, village health, and traditional medicine. In India, there is Ayush, which is actually a ministry of what would be called kind of traditional medicine or alternative medicine, which isn't a great word, but basically it brings together healers and provides a framework from the governmental level to the practitioner level for Ayurveda, yoga, naturopathy, Unani, Siddha, and homeopathy. These practices exist alongside biomedicine in India, so you really get to see how there's a collaboration between traditional or alternative non-Western, non-biomedicine approaches and biomedical approaches. And certainly there is much evidence base for some of these practices. So I think, again, our language is limiting. But if you're interested in primary care and village health, rural health, community health workers, health extender programs, how do we build health systems that meet patients where they're at when we don't have enough doctors? This would be an amazing program. It also is in the foothills of the Himalayas in Dehradun and Rishikesh, which is a spiritual mecca. It's where the Ganges flows out of the mountains. and where Hindus are drawn and other religions are drawn toward many spiritual traditions. So you get to see that in action alongside your clinical exposure. In the Philippines, the program is designed to understand how the Philippines government and Ministry of Health has built a health system. They have an archipelago of over 2,000 islands, and so they've had to build a health system that provides care that is in the most rural, remote settings. They're called barangay health stations. And so your first week is spent with the Ministry of Health in Manila, learning about how the health system is designed, also rotating at the University of Philippines hospitals and tertiary care centers to see how kind of the urban health environment is. And then you spend the second to third weeks in the rural islands with the barangay health station, which is composed of nurses, midwives, usually one physician, an island physician, depending on the size of the island, and really learning about how the health system is intentionally designed, how triage happens to get patients to a higher level of care, and how a lot of things are dealt with at a very rural level in incredible ways. In Ghana, there are two options, two locations. One is in Accra, which is the capital city, and one is in Cape Coast, which is actually one of the anchors of the slave trade. The Accra electives focus on pediatrics, both inpatient, outpatient, malnutrition, refeeding. There's also specialty rotation options. So if you're interested in nephrology, there's an option for that. When you're interested in a specialty, if I'm not mentioning it here, when you apply to an elective, mention in your application what specialty you want to do. We also have advisors available, so we can talk you through which rotation sites are the best for particular subspecialties. In Accra, we partner with Princess Marie Louise Children's Hospital, which is the largest children's hospital in West Africa. It is where Kwashiorkor malnutrition, which is protein calorie malnutrition, was actually first recognized. And so this hospital is, you see it, it's actually the picture in the upper right there. It's just absolutely phenomenal. And they have some of the most amazing experts in West Africa there, and just a team that is so dedicated to health equity and access. And then in Cape Coast, the partnership is with the teaching hospital there. This is a, I would say, a mid-size kind of hospital. It has various wards. So if you wanted to focus more on like surgical care, obstetrics, emergency medicine, or do more broad-based inpatient care and see all the wards, this would be a good rotation. I had the honor to be in Cape Coast in November, and I will say that I think it's really important to recognize that this location was also where the slave trade was established and where they routed slaves to then leave to colonial destinations. And so part of this program is also recognizing the history of slavery, of Pan-Africanism in Accra as well. Ghana is really kind of a focal point for Pan-Africanism and the idea of African unity, and really appropriate claiming of the power of the African subcontinent. So this program is transformative in multiple ways. So yes, you'll be doing an amazing elective, but I also think that you need to recognize where you're going to be and the gravity of the locations and importance of the history. And that is interwoven into your elective. So you will be, the program and the elective also includes going to key sites and understanding the historical context, both of the country, region, and the global history. Uganda, which is in East Africa, there are two sites. One is in Southwest Uganda in Kabale. You actually land in Rwanda and Kigali, and this is about 2 hours drive, and you're picked up by our local team. In Kigali, you go to the Rwandan Genocide Museum to understand the history of the genocide and the colonial roots of that. And then our team accompanies you, and then you are driven to Kabale. On the way to Kabale, you pass through a border town where there's also a satellite clinic. This program really focuses on a non-governmental NGO-based health system. And that health system provides kind of a broad-based understanding of kind of frontline healthcare. So it includes primary care, it includes kind of focus on public health and population-based interventions, the intersections of social determinants of health, such as nutritional status, economic development, protein sources, transportation, displacement of Indigenous persons and the impact that has on their health status and their living and working conditions. So this program is if you are uniformly focused on I only want to do cardiology, this is absolutely not the right program for you. This program is really for you if you want to immerse yourself in a community-based East African context where you're understanding how an NGO is addressing health in multi-faceted ways, including clinical care, public health, social determinants of health, socioeconomic development. And the partner that we have here also partners with USAID for both PrEP and ARV treatment. And so if you're interested in how PrEP is being utilized to prevent HIV, or you're interested in how ARVs programs run in sub-Saharan Africa, this is, I think, one of the strongest sites for that. Mukono is outside of Kampala. It's northeast of Kampala, and it's a district where our partner OmniMed is rolling out and ensuring sustainability of community health worker program. So this is an NGO where you are actually focused more on capacity building, which means training and developing the healthcare workforce. So really understanding as physicians, how do we partner? How are health extenders, such as community health workers, trained? How is the quality of community health worker engagement measured and sustained? Also looking at water sources and tracing burden of disease and the maintenance of water sources. So if you really want to be in a clinical setting like a hospital or clinic, this is not the right program or not the right elective for you. But if you really want to learn more about health systems and how we go beyond physicians as a solution, this is an amazing opportunity. In South Africa, there's two programs. One is in Durban, which is a Zulu city, and the city that has the highest rate of HIV in South Africa. This rotation focuses on kind of exposure and a tiered health system. So we didn't talk too much about tiered health systems, but they are essential for resource allocation and ensuring that, people who need primary health care versus secondary versus district versus tertiary and referential healthcare and academic centers are at the right level of care. And so this rotation allows you to really rotate through all those levels of care, including, the primary healthcare at the home-based level with visiting home nurses and community health workers, up to more of specialty care. If you're interested in focusing exclusively on, let's say, emergency medicine, this would be a great rotation for you. Or if you're interested in focusing on hospital medicine or inpatient care, this is a very strong rotation. Cape Town is a very popular site. It is a program that focuses on post-apartheid South Africa and understanding how apartheid has informed health disparities that exist today. In addition, South Africa has the highest Gini, or one of the highest Gini coefficients in the world. The Gini coefficient is a measure of the disparity between the richest and the poorest. So for those of you who aren't familiar with apartheid, there was a huge resettlement of Black South Africans during apartheid into townships. And so you will explore the history of the creation of townships, how townships impact health status currently, how health is accessed by the township populations, This is mainly inpatient medicine, but there is a growing availability of outpatient medicine as well. Also, palliative care is available here, and we partner with Victoria Hospital and Dr. Clint Kubido, who is really a leader in palliative care in South Africa. And so if you're interested in palliative care, this is a great opportunity for that. I'm biased because I'm a palliative care doc, but also inpatient care, we partner with Red Cross Children's Hospital, which is also the pediatric trauma center. So very strong inpatient pediatric rotations available here. In Argentina, I will mention all of our Latin American programs are conducted in Spanish. So some of them require a minimum level of Spanish, and our electives in Argentina, which are in Cordoba, which is a university town in Argentina, Cordoba, excuse me, it does require minimum Spanish. You also have Spanish language training in all of the Latin American sites along with your rotations. If you're interested in hospital medicine, infectious disease, nephrology, oncology, emergency medicine, these rotations are going to be slightly more familiar feeling. I would say their structure is slightly more similar to what you're used to if you're coming from a US or Canadian or high-income country context. Ecuador underwent healthcare reform in 2009, which came along with a recommitment to health as a human right, to building a primary care-based health system, also to integrating sexual health rights into the Constitution in a Catholic dominant society. This rotation is under the leadership of Dr. Susana Alvear, who is a leader in family medicine and healthcare system building in Ecuador. There is inpatient and outpatient rotations. You will be placed in a variety of different settings. If you want to focus on one more than the other, there is an opportunity for that, but I would also encourage you to be open to kind of doing different settings each week, because I think it gives you a really important understanding of comparative health services. There's rotations at the maternity hospital, at the military hospital, at primary care clinics. In Mexico, the rotations in Oaxaca, which is in southern Mexico, focus mainly on either primary care or hospital medicine. This is a good site if you don't have a lot of Spanish, so you can kind of do a more ramped up Spanish training here. So we have a beginner Spanish program where you can focus more heavily on language and less heavily on your clinical rotation. So if you're trying to improve your Spanish for residency, the Oaxaca program would be one of the ones I recommend for doing that in an efficient way. The Ecuador, the Quito program is also good for that. In Puerto Escondido, this is a coastal town where the focus is on kind of the Ministry of Health's provision of primary health care, Centro de Salud's, women's health, and the use of parteras, which are lay midwives, although lay is not a good term, but midwives that don't go through the training that you and I have gone through. And this Spanish requirement is higher, so you need to have an intermediate level of Spanish to do a rotation in Puerto Escondido. On our website, we have a Spanish self-assessment, so you can look and see which level you are at. In Bolivia, there are two locations. One is in Tarija, which is in southern Bolivia near the Argentinian border. This is a more rural setting focused on primary health care, but there's also opportunities for inpatient rotations. This is a site that requires more intermediate Spanish, so you have to have a higher level of Spanish to be accepted into this rotation. In addition, there is a strong focus on infectious disease such as Chagas disease, TB, rabies, malaria, yellow fever, and typhoid. We work with the National Chagas program here. So if you're interested in doing infectious disease as a subspecialty, this would be an amazing rotation to get under your belt. In La Paz, the focus is on pediatric medicine, mostly inpatient, but also some outpatient. You will rotate in the tertiary pediatric hospital in La Paz and in a community-based pediatric hospital and practice in El Alto, which is the more indigenous kind of less socioeconomically well-off suburb that's on the hillside outside of La Paz. There's also specialty rotations available here. This is a site where our medical director, Dr. Tora Cecilia Uribe, and Gonzalo Clore, who is our local coordinator, have deep relationships. And so if you want to go to La Paz, but you don't want to focus on pediatrics, I would say to put that in your application, and they are very accommodating. So obviously your health and safety when you're abroad and when you're doing rotations is utmost important, as well as the health and safety of the community. And so we have a director of health and safety, Bethany, who is available and does a very robust pre-departure training. We also buy you all your insurances you need to ensure that if you get sick, that you have health care, you have the opportunity to be evacuated. We have built out health and safety protocols. So if your school, particularly if your school needs to approve your elective and they want to know that CFHI is going to keep you safe and healthy, I'm happy to speak with your school and kind of go over all of our protocols. There's a variety of ways that we keep you safe, and this is available on our website. I want to also mention that there's a lot of circumstances that people are in. Traveling is not always realistic for a variety of reasons: jobs, kids, documentation status, other reasons. So we have virtual offerings, including virtual global health electives, but also other virtual offerings. So please don't let travel be a barrier. Our virtual global health elective is designed for final year medical students and generally has students from multiple low and middle income countries participating. And it runs usually in March and July. So we're just about to have a cohort. And there are scholarships available for both our virtual and our place-based or in-country programs. We have dedicated fourth-year scholarships, both the Lolliger fourth-year scholarship, as well as those that are AMSA members. We have scholarships particularly dedicated to our off the beaten path electives, which are those that are in Uganda, Ghana, in Tarija, Bolivia, in Quito, Ecuador, and other sites. So if you want to go into an off the beaten path program, please see those scholarships. And we have a scholarships webpage, or you can Google it. So how do you apply? I hope that you're excited either as a student wanting to participate in an elective, or as a faculty member or administrative leader wanting to partner with CFHI. The application process, generally you need to apply at least 3 months in advance. Generally, medical students are applying much farther out because you need to kind of set your schedules now for next year. Or if you're a third-year student, you'll be asked probably in the, at the end of, start in March, April, May, start to think about your fourth-year schedule. So apply early. There's no application fee or anything. Just go to our website, create a profile, submit an application. We will review that. If you're not sure which elective to apply to, I'm going to give you an email address to email, and we're happy to have a conversation or point you in the right direction. And then once you are accepted, you have pre-departure training and requirements before you go, and then you either go virtually or in person to your elective destination. The email is students@cfhi.org. I also will give you my personal email, hoping you can see these chats, but it's jeverett@cfhi.org. I have a few moments to take any questions. Okay, so there's a question about how long it takes to prepare. So generally you're applying at least 3 months in advance, and then the preparation is over the 4 to 8 weeks prior to departure in terms of all the pre-departure training and the orientation. There is a cost to these electives, which is why we provide scholarships and is aligned with Fair Trade Learning. The cost of the electives are generally, around $3,000, which includes all your room, board, 2 meals a day, your elective and all the mentoring, all the insurances, pre-departure training, on-site support, orientation, health and safety, and kind of everything except for flight, spending money, and 1 meal a day. And all those prices are on our website. So it's about $3,000, which is why we provide scholarships. And then the virtual programs are designed to be much less expensive. The virtual elective is $500. And many students are able to use their financial aid to support their elective when they're getting credit. So if you need help with that, let us know. And if you have other questions, type those in the Q&A. All right, I don't see any more. So thank you for your time, and let the world change you. Please be in touch and take good care.